Liz Horn, welcome to the Tick Boot Camp podcast.
Thank you for having me.
So, Dr. Horn, today is actually a very special podcast. We finally were able to persuade Ali Moresco to rejoin us. Ali will often join us and then, of course, need a break because, one question or another that Matt will ask will cause her to want to just take a break from the podcast. So, I'm happy that Ali's been able to recover from whatever weird question Matt had asked one of our guests in the past, and now she's willing to join us. So, Ali, please say hi to the folks.
Or Matt, I'm just happy to be back. Thanks for having me.
Right. So, Dr. Horn, this is not the first time I've met you, although this will actually be published before the episode you and I had done together on the biobank, which was an awesome interview. I really loved interviewing you on that issue, and perhaps we'll have a long form interview on that because we've had a lot of folks share with us some of the really cool research they've been able to do as a result of the biobank. But rather than getting knocked off on a tangent before we even get started, can you first introduce yourself to folks?
Sure. Hi, I'm Liz Horn. I'm a scientist and I'm the principal investigator of Lyme Disease Biobank. And I've been working on this project since 2013. And I'm really honored to be working in Lyme disease. It's such a challenging problem, but it's also incredibly interesting scientifically. And we've been able to do some really amazing things with the biobank. And I'm excited to talk to you about a recent study that came out of it.
And we cannot wait to talk to you about that study either. It's one of the most often I guess discussed topics. But before you go there, let's go talk a little bit more about your background. Talk us about where you went to college, where you got your PhD from, and what kind of work did you do prior to joining the biobank?
How long do we have?
We have,
I'm kidding.
we have
Okay.
enough time
So,
for folks to learn who you are, so they have a
yes.
proper context for this larger conversation that the four of us are going to have together.
Right. Okay. So Lyme Disease Biobank is a program of Bay Area Lyme Foundation. I am actually in Portland, Oregon, but I grew up on the East Coast. So I grew up in Pittsburgh, Pennsylvania. And so we obviously knew about ticks, knew about Lyme disease because it's been a thing for quite a long time. I went to graduate school at SUNY at Buffalo, and
Wow, a New York gal.
yes, and it actually does help when you are when you have a Lyme disease biobank site on Long Island. It helps that you at least spent some time in New York, even though it was on the other side of the state.
Yeah,
But
yeah.
I was working on my PhD. I'm a cancer biologist by training, and my advisor moved the lab to Portland, Oregon. And that's how I got out to the West Coast. And because of that, I had a lot of experiences, administrative experiences, because I was the first person out there. And then when I did graduate, earned my PhD, I was recruited to a nonprofit organization to help build a research program for them focused on a biobank. And I've worked in a lot of different disease areas. I've worked in autoimmune disease, I've worked in rare disease, and in 2013, I started working in infectious disease on Lyme disease. So
All right.
it's been a lot of different experiences, but it's helped me get to where I am and build this program.
Can you just give us on a high level, because I know folks are going to want to know what the biobank is, and you and I did a longer interview on the
Mm.
biobank, but you and I keep referencing it. Can you just give a quick outline of what the biobank is so folks are not wondering what that really cool work is that you're doing there?
Sure. So a biobank is a collection of samples, and in our case, it's human biologic samples. So think about a biorepository or a library where you're able to store books. A biobank is a place where you can store samples, and we've focused on people with Lyme and other tick-borne infections as well as controls. We have samples from people with early Lyme, with persistent Lyme, and we also have a tissue bank. So we cover a broad range, and again, we've been working on this for more than a decade, and we have more than 1,250 participants, and we're really grateful for all of them for donating samples.
All right. So now let's get to the subject at hand, because one of the most challenging elements of Lyme disease is testing.
Right.
And we've had a number of different interviews with folks who are either working at labs or working on testing protocols. And And of course, most of the people that are going to be listening to this, Dr. Horn, are folks who are in the patient community. And they often feel gaslit when they're told that by a doctor or healthcare professional, that because they did not test positive for Lyme disease, they do not have Lyme disease. So can you first share with us what type of testing is available in the Lyme community, and what was the focus of your recent study?
Sure. So, one of the big challenges in Lyme disease is that we do not have good diagnostic tests. And one of the huge gaps is that we don't have a direct detection test that identifies the pathogen, that identifies the bacteria that causes Lyme, which, as many people know, is Borrelia burgdorferi. What we do have are indirect tests. So they measure antibodies. So your immune system makes antibodies in response to a pathogen. So basically, when we do a Lyme test, it's a serology test, and we're measuring antibodies, and they're indirect. And it also takes a little while whenever we're exposed to something, for our immune systems to identify it and react to it. So it can take a few weeks to develop antibodies. So there's a huge gap right there, right? So we're measuring something that's indirect that can take time to develop. So especially in early disease, a lot of people will test negative. And in early disease, a negative test is unreliable.
Okay, so
And
let's pause there for a second, it's because I want to make sure that we're defining the scope here before Ali and Matt join us as the patient members of this group conversation. So let's remember we are talking to a broad spectrum of folks. We have some people who are just newly diagnosed with Lyme disease. We have folks who are wondering if they have Lyme disease. We have caretakers who listen to this podcast. So we're gonna walk it down on two different fronts. The first is, we here at Tick Boot Camp define Lyme disease a little bit more broadly than most folks do. And we define Lyme disease as a polymicrobial, multisystemic, chronic infectious disease. So we tease out acute illness, and we recognize that it's many microbes that in most cases will be dogpiling on your system, ultimately resulting in a chronic illness. Now, the focus that you just gave to us is more narrow, which is you are focusing on one strain of one microbe, which is generally what's tested. So generally, when we have people who are sick, one of the problems that we have is we have no testing at all for many, many microbes, or many other strains of the microbe. So can you just focus now on the testing that is available and the testing that you focus on in your study?
sure. So the testing that is available is their antibody tests, and again, focusing on Borrelia and not the Lyme plus, which is a huge problem. And most of our focus has been on early disease. And that's really because when we started the biobank, researchers didn't have the samples they needed to develop better not diagnostic tests. So we really wanted to create well-characterized samples so we could get to better tests. But one of the side effects of this is that we also get the data back about the biobank when sample users are using our samples. And this study that came out is a result of the data we got back from a research question they have. And again, it's more focused on acute disease, and so this early disease, but we definitely have huge gaps in diagnostics across the spectrum.
Okay, so let's talk about acute versus chronic,
Right.
because that's another part of narrowing the scope here. Obviously, the earlier we can diagnose a disease, the earlier we can intervene. The earlier we intervene, the more likely it is that we're going to be able to prevent someone from becoming chronically ill. So your focus is not on somebody who's chronically ill. Your focus is on trying to properly diagnose symptomology that someone has, so that there can be intervention at as early I guess a stage as possible. Is that a proper description?
For this paper, yes.
Okay.
Right.
Now,
And so everything we've been talking about, persistent and chronic illness, we're working on that too, but it's outside of the scope of this paper, and I'd love to talk to you about it at a later date.
yes.
Or maybe when we get to the end of this interview.
Yeah. So
If there's time.
yeah, Matt and I have all night. So if you want to stay,
Yeah.
we'll stay.
Liz, you
So,
don't know what
I'm
you're getting
three
yourself
hours
into here, Liz. Just be warned.
Hey,
I'm
I'm
kidding.
3 hours behind you, so you know.
So the next thing I want to focus on with you, just again, keep the scope
Yeah.
narrow, is how the immune system works, right? Remember, we have folks who don't understand what the immune system is, And can you explain how the immune system responds to these bugs that would be spit into your system by a tick that is biting you, and what an antibody is?
Sure. So really there's two parts to our immune system. So there's the first part is non-specific. So when you have something, we'll just call it something foreign that gets in, it could be a bacteria, it could be a virus, something that is not supposed to be there. It very non-specifically creates a response to try to get rid of it. And a lot of these are, when you get a fever, it's really because your immune system is like, wait, something's not supposed to be here. We got to take care of it. We've got to release these cytokines. We have to attack the intruder. There's another part of your immune system where you develop antibodies and you can create memory and you can see things that your immune system will identify things it's seen before. So it's a little bit it's a more complex process. It's more specific. And that's really where we are looking with the antibody tests that we have available right now.
Okay, so now let's talk about again I think the last piece of this focus is, so there are different types of testing.
Mhm.
There's testing that's going to be looking for antibodies, and the reason you are calling that indirect is this test is not looking for the bug itself or any of the DNA from the bug. It's looking to see whether or not your immune system has responded in a particular way to this particular type of bug or germ that was spit into you, correct?
Exactly. And sometimes you'll hear the term host response. So we're the host. When the bug gets into us, it's not supposed to be there. And so, yeah, we're the host.
Okay, so just so that I can sum this up, and I know Matt is jumping out of a seat already. Just so I can sum it up.
Truly.
So from the standpoint of the channel that we're reviewing now is that the FDA approved testing for Lyme disease is permitted for one strain of one type of germ that could be spit into you by a tick who's biting you. You're focusing on what this testing does is it only looks for an antibody response, not for anything that's directly there. And what your paper was looking at is how early this test could be effective, if effective at all, when it's provided to a patient who suspects or whose physician suspects that they may be suffering from Lyme disease.
Yeah, and I think unfortunately the testing story gets a lot more complicated because the way that so they're called FDA cleared tests. So the approval process is for drugs, and to get a diagnostic, it's a clearance process. So our our FDA cleared tests are two-tier tests. So that means it has two steps. So you have to after the first step, you have to get a positive result or a borderline result to even get to the second step. And our standard two-tier test, and these are the ones that were developed in the 90s, and we've been using them for a long time. The first step is an ELISA, so that's a way that you can measure an antibody response, so you can actually detect it. You can get a reading from it, so you can get a specific number, and if it hits a certain threshold or is equivalent to a threshold or above a threshold, then you run immunoblots. And so these are you actually load a sample and you run the sample down and you look at different bands because the proteins will separate into different bands. And so it gets pretty complicated. So that's the standard two-tier test. And then I think it was about 2018 or 2019, they created a modified two-tier test. So we took the immunoblots away, and it's still two steps, but you have to do one ELISA, and then it's followed by additional ELISAs that are based on different targets. So it's pretty complicated for the lab. It's not just like a simple test that there's a value or there's a yes or a no answer.
Okay. So the question that you studied, I'm gonna bring it down to really blunt terms, is does this test suck? Or does this test not suck? Right? I mean, it's really what we're trying to determine. I mean, is it something that we should be using, or is it something we shouldn't be using, or do we need to make sure that the patient community is served better by focusing on on other types of testing?
So I'm just going to take a quick step back. So this study is actually kind of complicated, but the genesis of it was, so when we were collecting our samples from Long Island and in Wisconsin, the upper Midwest, we wanted East Coast and upper Midwest. We wanted two different geographies, and we were looking for people with signs and symptoms of early Lyme, and we were working with practitioners that are in endemic areas and are knowledgeable about Lyme. So people are coming in within a few days or a week of being exposed, either noticing an EM rash, which is the expanding lesion that some people get, but not all people get, or they just had a history of tick exposure and the provider suspected Lyme. So that's how they got enrolled in the biobank. And we collected people with Lyme rashes and without, because we know not everyone gets a Lyme rash. So it's much more of a real world collection. And then at the end of the season, we ran our own testing. So we worked with the Mayo Clinic. We ran an ELISA followed by Western blots. And we did it on all the samples, including the controls. Now, I mentioned that to get to the second step, you had to have either a borderline or a positive result. We didn't follow that. We just said, hey, we're running all of these tests on all the participants in the biobank and we'll get the data back. And then we had a sample user who had, and these were with an FDA-cleared test run at Mayo Clinic. And then we had a sample user who wanted to test their standard two-tier test and their modified two-tier test, and then another competitor's test. So now we had this paper, there are 4 tests, so 2 standard two-tier tests and 2 modified two-tier tests. But what it does is these are 4 tests that you can get on the market right now that are available in clinical labs, and we compared them to each other in this population of people with early Lyme disease. So we learned a lot. And then we also, in addition to showing that, well, they didn't work very well, we were able to show who they worked on, and that's really important.
Wow. All right. So now that I framed this, come and join us, patients,
Yeah.
because I know Matt and Allie
Yeah.
have a lot of
And
fun.
sorry, it's a lot. This paper is so confusing. I mean,
No,
there's just
no.
going on.
Dr. Horn, there's a lot of good stuff here, but I think where Rich failed, and he failed in many spots, but I'm going to focus on the first spot that Rich failed in this conversation so far, is when you were talking about the standard two-tier testing and then the modified two-tier testing. So we said, okay, the standard two-tier testing has been around for decades, and then maybe about 10 years ago, they came out with the modified two-tier testing. So you explained it really well that it's going to be the ELISA followed by the Western blot. So it's a more non-specific to a more specific antibody response to look for bands. I'm going to focus on that piece first, and then I want to get to the modified two-tier testing, because what we hear often at Tick Bootcamp is with the standard two-tier testing, it changed in the 90s around the time the Lyme vaccine came out. Is that true? And if so, what bands were modified on the Western blot, and what impact did that have on the diagnosis of Lyme patients?
So I don't know the answer to that question because I haven't been around long enough. So
Fair. That's a fair answer.
yeah, but I do have someone that I can ask, and I totally can get back to you because I think that's an important question. And I think one of the things, if you think about a Western blot or an immunoblot, like it's just a strip with lines on it. So there's so much subjectiveness, right? So you have to decide, is that band really there? Is it dark enough? Or is that not a positive band? And so there's two different blots. And again, this gets so confusing. There's IgM and IgG. So these are 2 different immunoglobulins, so 2 different types of antibodies. And sorry, you're getting a biology lesson. This is not.
No, this
is good. We want this. Please keep going.
And we'll see if I remember it all correctly. No, but the thing about IgM is it comes up early. So that's why, and again, with the test, it matters if it's within the first 30 days or after. So the IgM is an earlier response. So it's going to come up and then it's going to stay up for a while and it'll come back down. That's the one they look at it the first 30 days. And then the IgG response, it's a later response. And you can, if it's positive within the first 30 days, it's still fine, it's still positive, but you can look at it after 30 days. And current CDC guidance, you can't look at the IgM after 30 days. So I told you this is really confusing, right? So,
but I think it's important. So you just repeat, Dr. Horn, you said that you can't look at the IgM after 30 days, correct?
Generally, that's CDC's guidance.
Right.
So
Please go. I think we're going to ask the same
I
thing,
know.
Al.
I'm stuck on so for the Western blot, you said basically it's a strip of paper that, gets, I guess, tested, and
Mhm.
then there's lines that come up. So I'm guessing that there's guidance for what type of line means what, or if it's faint or bold, but is there then human bias that comes into that testing?
Well, and I'm not sure if I don't even know if I would call it bias. I
Even if
it,
it's unintentional.
yeah, error is not the right word, but so they take their targets. So the antibodies are in your blood, technically your serum, and so they're going to use antibodies from your serum against this strip of paper, this blot. But they've had to put antigen. They've had to put these proteins, or either proteins or recombinant proteins, in the places where you'll have these different lines will show up.
Mhm.
And so you have to have antibodies in your sample, in your blood or serum, to bind to what's on the blot for it to be positive. Now, depending on how many antibodies you have, it might be a darker band, it might be a lighter band. Maybe when they were spotting the bands or putting the targets on it, maybe they didn't get as much on it. Maybe some of the buffers didn't react as well. Like there's just a lot of steps and a lot of things that can happen. And then you need someone to look at it and say, is this dark enough? Does this count as a band? So there's just there's just a lot, there can be differences in interpretation.
Mhm.
So it sounds like it's a buggy test, right? I mean, there
Yeah.
are just so many different steps that have to be taken, and there's so many different places for human error before
Mhm.
you even get to the point where whether the human is seeing the band or not. There just could be so many different places where the test could fail just purely from the way it's designed.
And I'm
Mhm.
sure we're getting to things where you can have automated reading of it and not just, but yeah, but especially, and back in the day, and no one's really doing this anymore, but they would just they would make this thing called a whole cell lysate. So they would grow up a bunch of the bug and then just sonicate it, break it up, and then just, run it on a gel, transfer it to the membrane. And that's what they were looking at. And that had a lot of possibility for different interpretations, right?
Hmm.
And different challenges with the steps. So it's also time consuming, right? So you have to do the second step. It's expensive. So I think that's really why there was this push to go to the MTT, because with the MTT now you're running the same like biochemical assay that you were the same, you're just running ELISAs, and it's faster and cheaper.
Yeah, Dr. Horn, before we get to the modified two-tier testing, I want to follow up on Ali's question because she sparked a thought. If you're basically looking at a sample of blood and you're looking to say, is there an antibody in that sample of blood that's reactive with this antigen, which is basically indicative of the bacteria, right? Now, I think to Rich's point, it's a flawed test, it's a buggy test because that sample of blood may or may not have the antibodies in it, right? That's a risk to determine a positive result or an accurate result, I should say. But more importantly, you also mentioned that you studied autoimmunity. And with these antibodies, I think that's a component. And I think there's two sides to that spectrum where if I have an overreactive immune system, we've heard doctors tell horror stories with people having all kinds of crazy immune responses after the pathogens were gone. So if you're seeing an antibody for Lyme disease, does that mean they definitively have Lyme disease? It could mean they have an autoimmune problem where they're just going haywire potentially, right? On one side of the spectrum. Whereas on the other side of the spectrum, they could be so immune compromised where their immune system is so just beat up that they have an active infection that's spreading and causing all kinds of chaos in their body, but the immune system simply isn't responding to it because it's so just defeated. So I feel like that's another flaw or a bug, as Rich noted, in the testing as well. Am I right? And you can tell me, don't be polite if
No,
I'm wrong. Correct me,
no, no,
please.
no, you're absolutely right. So our antibody tests can't tell you if it's a current infection or a past infection, because sometimes we still maintain antibodies over time. And it's important we maintain antibodies because if you get exposed again, your body's like, oh, hey, I recognize you. And it mounts a much faster response to get rid of the pathogen or bug. So, and for people who are immunocompromised or immunosuppressed, they won't mount as strong an immune response. And in those situations, they might not test as positive. They might. So when we talked about the bands, so for IgM, you need 2 out of 3. And for IgG, you need 5 out of 10. So what does it mean if you get 4 bands? And what if you have 4 really good, strong bands and that fifth band is kind of light, but it's still sort of there faintly? And again, that's where the subjectiveness. Now, some physicians really like the blots because it can tell you about the immune response and what antibodies are coming up. So all of these targets are antigens, like they're Borrelia specific. Well, some are more specific than others. So P41 is to flagella, and flagella is so it's the motor that makes the Borrelia swim, but other bacteria have flagella, right? It's not unique to Borrelia. So it's you're trying to look at this whole picture and it changes over time. So even people that are tested now and maybe tested in the future, they might have a different banding pattern. And 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 it's a huge problem because you don't know if that infection is current.
Right.
So
And
it's
I just that's
I
what I want to
feel like we're
repeat.
getting it's very circular, right? It's
Yeah. And this yielded the results of your study, which were 64 to 78% of early cases of Lyme disease were misread by these tests, right? So you're missing 64 to 78% of early cases of Lyme disease. I mean, that is insane when you think about that. And I just had somebody yesterday tell me that they got tested for Lyme. They were bit by a tick. Within a few weeks, they had flu-like symptoms and headaches and fatigue. The test came back negative and they were told, no, you're good. Don't worry about Lyme. And that's just so wrong, right? And this is the research you're doing and why it's so meaningful to get out there.
so that is such an important story because a negative test in early Lyme disease is unreliable. It doesn't mean it doesn't rule out Lyme disease. And this is what I don't think clinicians know. And and then you have clinicians in endemic areas that may not be aware of this. So typically, if you're in an endemic area and you've been bitten by a tick and you have a rash, they're just going to treat you. They're not going to test you because the test is likely to be negative. And the CDC even recommends, and all the guidelines, if there's an EM rash, don't test. But I feel like there are probably a lot of clinicians that are very comfortable with laboratory tests and like to order a test and they want that extra confirmation. But what they don't really understand is that's not in early disease, you're unlikely to get laboratory confirmation. And so it's a huge challenge. And I think so with the biobank, because we've been testing all these samples we collected for 10 years, we showed this in 2020 that we missed 7 out of 10 people with EMs in early Lyme. But what this shows is now we're looking at 4 different FDA tests. We're looking at the STT and the MTT. And when the MTT came out, there's a lot of data that it does better. Even in our study, it does better than STT, but it's really incremental. And I think it's also what's the timing of the sample? How long has your body had the chance to respond to the bug? Because we have this really cool figure in the paper. If you're at 1 week out, and these were people that had the rash, so we asked them when they first, how long it had been since they recognized the rash. And if they were a week or less, neither of these tests worked well. If they were at 2 weeks, MTT was better. And after 2 weeks, it didn't really matter. So whenever anyone is using samples to tell a story or a diagnostic story, where those where those samples were collected and the characterization of those samples, it's really, really important because depending on the sample set, you might be able to show that MTT is much, much better than STT. And that's true from those samples you looked at, but that's not representative of everyone. So if a clinician goes and sees, oh, MTT is 80% better than STT, this is great. But if the patients they're testing are in that window where neither one works very well and the clinician isn't aware of these limitations of the testing, you're not going to have good results for your patient.
So did back when these tests, I guess, were developed and then being taught as like the standard for testing, did we just at that time not have the technology or like to know that they're so inaccurate? Because I hear a number like 64 to 78%, and I had always heard historically that the tests were less than 50% accurate, but that was always like kind of the standard that I heard, which is already unacceptable. But
Right.
64 to 78%, you hear that number and you're just like, holy cow. Like that
It's
is a
bad.
mass majority of
Yeah.
people that are slipping through the cracks. And I just hear that and I'm listening to you talk about it. And it is very, very complicated, which I am so happy you are speaking to because I see over and over again in these patient communities, people saying, like, come on, why can't we just have an accurate test? Why can't we just have an accurate test? Like, as if it's not that hard. And in
Mhm.
reality, not that I am a scientist like you, but I'm like, I listen to you talk and I'm like, I can tell this is really challenging.
Yeah, so
And I'm
I
like,
think,
how did this happen?
well, okay, so I think there's a couple things that happened. One, so when Lyme disease came out, people didn't know about it and they had to figure everything out, right? So when it was first identified about 50 years ago, they didn't have any reagents, they didn't have any tools, so they had to identify all these antibodies. So the people doing the early work really did a lot of really important and good things. But I think where we run into challenges is in those earlier days, people didn't know what it was. So there wasn't that awareness. So I think the patients that were donating samples, they were further along in their disease. They were sicker, right? And even within from 20 years ago to today, I feel like people are much more knowledgeable about tick-borne disease. I mean, we're in Lyme Disease Awareness Month. It's May, depending on when you're listening to this podcast. And this year, what is it like the most ER visits on record for ticks? Like there's
Yep.
so much awareness. I mean, I live in Oregon and I was in the car this weekend listening to the radio and the DJ was just like, "Did you hear that?" Again, this is not a science
Mhm.
radio station. I mean, it was like classic rock, and they were reminding us that there were ticks, and we don't have the tick problem that everybody has on the East Coast. So I think there's also much more awareness, and people are coming in earlier. And so when those samples were collected, is really important. And sometimes we don't know when samples are collected because you might just there's a big testing lab, and they might just have all the samples that were sent during a season. And
Mhm.
these are samples that tested positive, but they could be people that have early disease, people with Lyme arthritis. You know, if you've had Lyme disease for over a month and you were untreated, and we don't want that to happen, we want to catch it sooner because we want everybody to be treated so we don't have long-term consequences. Those people test positive. They're not being well, there are some misses with people with neuroborreliosis, which is another issue. I mean, it's just so complicated. And Lyme just isn't one size fits all. And then you add in other infections and Lyme plus. And so that's why we need to do a lot of work on diagnostics and we need well-characterized samples. But this is so confusing.
Yeah.
So Liz, let's talk a little bit more about our personal experiences. Actually, what the reason we started Tick Boot Camp was after Matt had become chronically ill, and he and I worked together on an employment related matter that I was representing him on. I had gotten bitten by a tick, and after I had gotten bitten by a tick, I went to my doctor's office with the tick itself that I was bitten with, because that was Matt's advice to me, to go to my doctor with the tick. Um, I there was some question about what the appropriate treatment protocol should be. And as a patient who wanted to play a role in making a decision about what type of care I was going to receive,
Mhm.
I wanted to know whether or not I should take antibiotics or not. I had some concerns about whether or not that was going to have an impact on my gut health, and I had some concerns about whether or not antibiotics was the best approach. If there was an accurate test that indicated that I had been, in fact, um, infected with bugs that would have been appropriately treated with antibiotics, and it would have been a no-brainer. But if I didn't have a test that wasn't giving me information, or I took a test and it said that I wasn't infected with the bugs, then of course I wouldn't have wanted to take the antibiotic, right? So from the standpoint of patient care, I do think that having a test that fails up to 75% of the time is really challenging when you want to be a proactive patient and you want to make a decision about what the risks are and what the advantages are of any treatment protocol.
Absolutely. And ticks don't just carry Lyme disease, they carry they can carry other things. And some antibiotics, doxycycline, which is predominantly what's prescribed covers other things, but doesn't cover everything. So it's really challenging. And I think not only having an accurate diagnostic early, it would be really great to have a test to know if the treatment was successful. So with the last time we talked, we had just published a paper where we found that 1 in 5 people with early Lyme who were treated, these are some of the same people in the study we're talking about today, 1 in 5 of them still had ongoing symptoms of Lyme at 3 months, and they were treated with doxycycline and
There's a, there's a,
identified early.
there's another piece of this that I want to focus on with you, and that is testing that will allow doctors to feel comfortable with not only diagnosing but also prescribing care.
Mm.
Because we understand that we live in a litigious society. Not something I'm going to apologize for as a lawyer, but because we live in a litigious society, doctors are often very cautious about prescribing care when they don't have a diagnostic test that's supporting the care decision. So, for example, if somebody has the symptomology of Lyme disease, but the test indicates that they don't have Lyme disease, I think a doctor would be less inclined to prescribe a certain treatment protocol because they would then, I think, believe that they were stepping outside of the standard of care, and because they were stepping out the standard of care, they're creating some potential legal exposure for themselves. So there's problems on both the patient side when the patient is being proactive in deciding what type of care they want for their condition, and we haven't even brought in patients who have other types of medical needs which may or may not cross indicate with a certain type of treatment, but then we have doctors who don't want to put themselves in a position where they're either going to find themselves before the education department or a medical board, or they're going to find themselves in a courtroom because they prescribed something that they didn't have a positive test result for.
Yeah, it's a challenge. And antibiotic resistance, that's real. And, I know that there are people that, physicians that want to be good stewards of antibiotics because, again, we don't want a whole lot. There are a lot of antibiotic resistance bugs that are really challenging. So it's just so complicated. But I think the gap in medical education is, well, one, medical schools do not do a lot of education on Lyme disease, right? So we have a really challenging disease, and it's not just Lyme, it's Lyme plus. So we'll just call it tick-borne disease. But we have a really complicated test. It took us how long to just even lay out the basics of the test? And you think about a lot of the blood work you get or chemistry, you see your results in your my charts and you get a value and here's the range. It's in or out of the range. It's positive, negative, maybe it's borderline. And these tests are just a lot more complicated. And I don't think everyone really understands the limitations.
For sure. So you teased a little bit about you studied different tests. I think you said there
Mhm.
were 4 different tests. So
Yeah.
can you define what the 4 tests were that you studied and which tests performed better and why you believe they perform better?
Okay. So this is where it gets confusing. So we had the standard 2-tier test that's run by Mayo Clinic, and Mayo Clinic is a very large reference lab.
Mhm.
So lots of places send their samples there. We had a test from Gold Standard Diagnostics, which was also a standard 2-tier. So we had 2 standard 2 tiers, Mayo and Gold Standard Diagnostics. Gold Standard Diagnostics also has a modified 2-tier. So we ran that. And then we also ran Zeus's modified 2-tier. So 2 STTs, 2 MTTs. The MTTs were better than the STTs, statistically significant. And one of the STTs was a lot better than the other.
Okay.
And yeah.
So you gave us a range, and one of the things that Matt and I were talking about before we began the interview is it's an odd range. You gave us a 64 to 78. So what does that mean? Is it 64 to 78? Some of the tests are 64%,
Yep.
some of them are so because you use 4 different tests, that's how you got that range of 64 to 78?
Yes. So basically, and I have a cheat sheet here because, like I said, it's confusing. So when we looked at 107 cases, and it ranged from 22 to 36% of positives that our testing picked up. So that's where we got it's the reverse.
So tw tw it, in the 22%, that means, help me with the math here. So it's 78% of the people who had Lyme did not test positive with the
Yeah, so
tests that,
the people that ended up in this 107, they were either had EM, so EM's a sign of early Lyme
which is
disease.
the
The
bullseye
rash.
rash.
Yes, but it's not always a bullseye. That's really
Okay,
important.
same
Um,
Christmas
rash.
tree, right?
well, it's usually red. It's usually red or pink and oval shape, and it expands. The hallmark of it is that it's an expanding rash. But I think if people and we had in our study, we took pictures of all the rashes wherever we could. And very few of them were bullseyes. We did another study where we looked at our Wisconsin pictures, and only like 6% of them were bullseyes. So
Hmm.
I think it's really important to not, especially if you're not in the field. Sometimes they're bullseyes, but not only. I really want people to know that because I don't want someone to see this big round oval shaped rash and be like, oh, it's not Lyme disease because it's not a bullseye.
Or even
It's
if they
Lyme
don't have
disease.
a rash, if they have symptoms, they're not necessarily, they may still have Lyme disease, right?
Exactly. And especially in endemic areas. I mean, these ticks are small. The nymphs are the size of poppy seeds, and the um, adults are the size of sesame seeds. That's really small.
Hmm.
So
So,
let's come back to these numbers. So
yeah.
78% of the people with one type of test, which is used in the US, would have tested positive if there was a competent test, but did not test positive,
Yeah,
which then
and another way like to think about it, so I told you that we had these two standard two-tier tests. One of them picked up 29% and the other only picked up 22%. So let me just put it in numbers. Out of these 107 cases, one picked up 31 and the other one only picked up 24. These are two tests that are FDA cleared that are completely fine to use. Seven seven people didn't test positive by the other test. I
Hmm.
mean, they're supposed to be equivalent. When you go for FDA clearance, you're basically saying this test is the same.
It's repeatable, right? It's a repeatable set of
Right.
instructions that
These
should
two
yield the
tests,
same result.
How
yes.
did these tests get FDA cleared then? Like it just, I just don't understand.
Well, honestly, and I've had a lot of these conversations with people that know a lot more about this than I do, and I think it really depends the length of time from exposure or infection for the samples. So they do better. These tests, because they're indirect antibody tests, they do better the longer someone has had Lyme, or rather, let me take that back. I said that completely not in a helpful way. The longer from exposure to testing. So if you're looking at 2 weeks or 3 weeks or 4 weeks or 5 weeks, you're going to do much better on these tests than you're looking at 1 or 2. And we just have a really early sample set that shows the limitations. And if you want to
Mhm.
show equivalence, you just need to get samples that are a month old and you'll pick them all up.
Hmm.
Mhm.
And we talked about antibodies and which antibodies come up first.
Mhm.
So the ELISAs are going after different targets. And so they they are two different initial targets and you get different results. And because these are two-step tests, you need a positive or borderline on that first test to get to the second test. Well, if the same person tests differently on these two first tiers, they're not equivalent. And when we looked at just the first tiers, so the numbers we were talking about, I was talking about looking at both tiers. If we look at just the first tiers, it's 54 versus 40. So it's 50% or 37% of the people that test positive. So if you get the one, so say you do, if you would have tested positive with test A, but you get test B and don't
Mhm.
test positive, you're going to have a negative test.
Mm.
And this discordance, this lack of concordance on
Mhm.
these early on this first tier, I mean, it really matters what's
Mhm.
in that first tier. And one of the challenges is that these tests are very looking at a small range, and there's some new diagnostics that are in development that are multiplex tests, which look at multiple targets. So they're looking at 5 to 10 things initially instead of just one. So you might have a much better chance of testing positive.
Dr. Horn, aren't some people though now testing out of the gate with Western blot and the ELISA? So, I hear a lot of people out there saying that doctors going and saying, I don't care what happens on the ELISA, do both. Is that true?
I don't know. I mean, it could be. I mean, so if you get the Western blot, then you'll get the results and you'll know what bands were positive.
Right. Almost like if you had a failed ELISA, but a positive Western blot, they're taking that to the bank. And that's what I'm hearing. And I'm not sure if that's reliable or not. It's probably the better question for you.
Well, if it's IgG, it's completely reliable.
Got
So,
it.
I mean, the challenges with IgM, and we we know that IgM does stay around for a little bit. Um, yeah, we just need direct detection. Going
For
for
sure.
antibody tests, it's just these just aren't. Yeah,
As Rich said, it's a horrible, buggy test, right? But
yeah,
I do want to. One thing you said earlier, you said that the modified two-tier testing was superior, but only in the earlier stages, in the first couple of weeks post contact with the
yeah.
tick, right? Then I think you said basically from the 6 to 8 week mark forward, the standard two-tier testing was equivalent to the modified two-tier testing. Is that
Well,
true? Is
so
it just for early, or did I misunderstand that?
so for in our sample set, so it 3 to 4 weeks after exposure or your first onset of symptoms, it didn't matter if it was STT or MTT. They both did just they both tests performed equally.
Got it.
So
But I
it's
think
in
it's
a,
a,
oh,
oh,
go
sorry.
ahead.
Oh, no, please finish.
Oh, no, you go.
Yeah, I was going to say, I think it's important to note, though, and maybe I'm wrong, and I need you to just keep keeping me in line, slap me around if I'm saying things that are incorrect. But this is all the earlier stages of testing. So now, if I have Lyme disease and I've been sick for 8 weeks, or I've been sick for 8 years, all this changes, right? So can you speak to that? Because everything we've said so far, I think, is just at the early stages in the first month or the first few weeks. And as you noted, after 3 weeks, it's a different story. So what does that look like? And I know this study was specific to the beginning stages, but how does that change so people listening understand the key differences between the timing there?
Yeah, and so one of the things we didn't talk about that just we've been talking about how this is complicated is many of our so in this study, we also had people come back for a second draw 3 months later. So, and we had them come back to check on how they were doing, took another blood draw, and all of these people were treated. And we talked about IgG coming up later. Well, IgG didn't come up because they were treated in less than 5%. It came up in less than 5% of the people, and it didn't matter what test it was. And that's a real challenge because the dogma is when you can always test for IgG later, and that's a hallmark of the immune response. And once we have antibiotics on board, then the immune response gets blunted and it's not reliable. And I just don't think as many providers know that. So if you test later at 3 months and they're like, oh, there's no IgG, you don't have Lyme disease. Well, the IgG is just not going to come up. So that's a huge challenge. And these tests probably, since many people were treated, they're not going to work well in that chronic persistent Lyme, which is where so many people struggle and where we really, really need some better
Yeah.
tests. Unfortunately, there's some good things in development, and I want people to have hope because we have so much more in the diagnostic pipeline than we did when I started a decade ago. And we still have a ways to go, but I think we're going to start to see some better things in 5 years. And we're already seeing, IGeneX's iDart was approved, and that test it is doing pretty well and is picking up more people.
I think that's a really important thing you just said. So if somebody is chronically ill with Lyme disease or has had an infection for a while, they've had some form of treatment, antibiotics or otherwise, then the traditional testing, whether it be the standard two tier or the modified two tier, those tests are going to be even more inaccurate because the treatment will have suppressed the immune response, and therefore you're even less likely to yield a positive result. I mean, we're talking you're at best, maybe 22% likely to get an accurate result, but after treatment, you're even less likely. So it's almost useless at that point for a chronic patient to do a two-tier testing.
Right. And it's, in our study, it was less than 5% were positive. And again, this is at 3 months, and we don't have those samples to go out further. But yeah, and that's why, it's really important that providers understand the limitations of these tests and how to use them, because
I just
tests
say
are
again,
expensive.
I'm sorry to interrupt, Dr. Horn, but
Yeah,
I am blown away. Did you say less than 5%
less
of
than
chronically
5%.
ill patients tested positive when they
I
had an active
literally
infection of
have
Lyme?
been
That's
like
insane.
taking
Well,
notes
wait,
because it's like absolutely mind-boggling.
well,
At
wait.
3 months though,
So
at
this
the
is at 3 months.
3 month.
So we don't know what happened way down the line, right? We only know what happened at 3 months.
Yep.
But if they're not testing positive at 3 months, I don't expect that they're going to test positive after
Right.
that.
And
So
did all of the individuals at that 3 month mark, had they been previously treated with something that was suppressing their immune, or it was a blend of?
it was the majority was doxy, but it was doxy and amoxicillin. But yeah, they all, because again, these were all early people, standard courses of doxy. And that's why in our previous paper, our recommendation is with the 1 in 5 people still experiencing ongoing symptoms. And again, these were people identified early and treated most in the first 2 weeks of having symptoms. Is we recommend that providers just check in after a course of antibiotics and say, hey, how are you doing?
Yeah.
Have your symptoms resolved? Because there's evidence from the early Lyme treatment trials from the 80s where if people were non-responsive, they gave them another course of antibiotics and they did much better.
Wow.
And I think that is completely lost. I mean, I think that's what happens with literature when it's, 30 years old, 40 years old. Not everyone knows the old literature, and these were studies from the 80s and the 90s.
Yeah. So Dr. Horn, I did read your study. And one of the things that I mean, granted, it was very deep. So you need to, again, tell me if this is a proper assessment. But in the short window of the first 3 weeks of being infected with Lyme disease, that even then timing mattered. So if you did a test and then you would retest, you would have inconsistent results. You would have a negative and a positive, or a positive and a negative within the short period of time. So even then it was super inconsistent within 3 weeks. Is that true before I ask the follow-up question?
Yeah.
Okay. So and then you talked about the seroconversion, which basically means you have, a negative test, but the antibodies develop further, and then you have a positive because the antibodies are stronger. Even that wasn't consistent. So I just feel like, all that being said, it's just all over the place. So again, I keep going back to Rich's comment. It's a really buggy test because as I was reading it, I'm like, there's 1,000 holes in two-tier testing.
Mm-hmm.
Yes, and the people that are going to test positive, so yes, we know these tests don't work, but who do they work on? And I think that's really important to understand. It's people with symptoms. And that's probably a reflection of your immune system mounting a response. So in this study, and this is regardless of whether it was STT or MTT, if you were going to test positive, you had more symptoms. So the difference between 5 days versus 2 days of symptoms. So, and on average, 3 more days of symptoms. Wait, I said that wrong, and I'm just going to backtrack. It's more symptoms. So it's 5 symptoms versus 2 symptoms, and longer duration. So 8 days versus 3 days. So 5 days more.
Wow.
And then when you start to look at the rash, the EM, you really need to have a rash for like a week before you start to test positive. So if you test too early, it's going to be negative.
But even in your study, there was a lot of what I read said that there were people with the EM rash, or the traditional expanding rash, and they still tested negative, correct?
Oh yeah, most of them do.
That's insane.
Right. And if they had symptoms, so it's having symptoms that make you more likely to test positive, and more symptoms and symptoms for longer.
So what about people saying that their doctors tell them to do certain things to bring out the Lyme before a test? So we've had people tell us, hey, I'm going to go and do as much exercise as I can and I'm capable of to try to bring it out. Or I'm going to go and try to, treat, or all these different like hacks or tricks or tips to bring out the Lyme bacteria to increase the likelihood of getting a positive test if you have Lyme. Is there any validity to any of those types of things? And if so, which ones are valid for people listening?
Oh, I don't know. And the other real challenge is Lyme. Okay, Lyme is so complicated. So Lyme doesn't stay in your bloodstream, right? It migrates to tissues. And that's why we created the tissue bank, and that's a whole other conversation. Um, so if the Lyme's kind of hiding, so it's hard, and if it's not in the blood, it's going to be really hard to detect it with a blood test.
Yeah.
And so that's why they're using the antibody tests. And yeah, it's such a challenge. And even for people that have had Lyme for a long time and have been chronically ill, we don't know, is it the bacteria? Is it fragments of the bacteria? Is it some kind of an autoimmune response? And it could be any of these things. And it could be different. It's likely different in different people, and it could even be different in the same person over time. And then you layer on, now we've added Lyme Plus, and there are other self pathogens in the mix, and it just makes it so complicated.
Yeah, but I think another conclusion I drew from your study was what you just said, right? Hey, is it an autoimmune complex as a result of Lyme, even if the Lyme is gone? Is it a fragment of Lyme after it's dead? We've read those studies, right? So the Lyme is not really active and moving, but it's just the residual Lyme that's causing immune response. But in your study, you found we know that somebody has active Lyme in their body, and we know that if they're symptomatic, it increases the likelihood of a positive test. So based on that, I drew the conclusion that it is the active infection causing the immune response because that's what your study found. Is that right? And again, tell me if that's a misinterpretation of your study.
It's possible. I mean, I think it's because ours are early. I mean, that's the thing. Everything that we have right here, we're talking early. We're talking within the first month for that our initial testing, and then 3 months later for the second testing.
Yep. Yeah. But to me, it's like sort of binary logic. I took a class in college and I loved it. It was just straight up binary
Yeah.
logic, true and true, true or false, right? To me, it's like that. So if you're saying that people with symptoms generally are testing positive more highly, and we know because of the study that those people ended up having an active Lyme infection, then at least in a large percentage of cases, people with symptoms have active infection, right? That's kind of where I'm going with this.
Or they are better able to mount an immune response.
True. Yep, I like that. Yeah,
So,
yeah.
because it could be, I mean, they could have more of a bacterial load, right? There
Yep.
could be more of the bug.
Yep.
They, um,
Yep. I
the
like
bug
this.
hasn't sequestered and their immune system can see it. Like there's so many possibilities. And again, this is what makes Lyme very fascinating from a scientific standpoint and very frustrating from both a clinical and from a clinical standpoint because, patients are suffering and we don't have good answers for them.
Yeah. You touched on something earlier. I don't want to forget to circle back to. So you're talking about the Western blot, and one of the proteins it looks for is the flagella, which is the tail of the spirochete,
Mhm.
which helps it move. We had another researcher on, I think it was last year, who told us that really something very fascinating, that the tick itself, when the Lyme bacteria goes from, let's say, a rat reservoir to a tick, the
Mhm.
tick midgut will supercharge the flagella. So when it goes into the human body, it's now supercharged and it's able to drill into your tissue and bone more aggressively. And in their study, they found that if they took pure Borrelia, right, pure Lyme disease, and put it into a human, the flagella was not nearly as rapidly moving, and it couldn't drill as deep into the human body and human tissue. Have you heard of that? And is that accurate? Because to me, it's fascinating that like this bacteria gets even like steroids, right, when it's in the tick first before a human being.
There's a lot of changes that happen to the bacteria in the tick midgut and then how it gets um, into the host. And I saw this. Yeah, I was just at. Yeah, it's so gross. I saw this image and it was beautiful, but it was basically like the tick and the proboscis just going into the skin and breaking the barrier. And but yes, I think what you're saying, like I've definitely heard of some, we're trying to understand this better, but yes, that the flagella can get supercharged and can, you know, helps it get from the tick to the person. And we're the dead end host. Like we're
Yeah.
not even supposed to, it's not supposed to be there. We're not helping. We're not helping the life cycle of it, you know?
Yeah. I can see Rich wants to jump in. I'm sorry, Rich. I'll
No,
pause.
no, no.
I see you going to speak.
We've had so many people on this podcast, Dr. Horn, who have said, I was one of the lucky people who tested positive on the traditional two-tier test. Just based on this conversation, what I'm going to actually tell folks is you aren't lucky, you're a miracle.
Yep.
The likelihood of you testing positive is so minute that if you do test positive, it is truly miraculous. I mean, it has to be the right test. It has to be at the right moment. You have to have the right people who are reading the test at the right. I mean, it's truly miraculous. I mean, your study is showing that under the best of circumstances, you're somewhere. You're almost certainly 70% likely not to test positive in the event that you are infected with this disease and you are tested with one of these four tests. But when you bring in all the other possible flaws in this test, and you add those permutations, it's not 70%. It's got to be substantially even higher than 70%. I mean, you just focused on the best case scenario. It's
Yep.
truly a
Right.
miracle that you test positive if you do.
Yeah, and the one thing we didn't touch on, so well, we talked a little bit about the Borrelia don't stay in the bloodstream, but there are a handful of people that will test positive by a direct detection test like PCR or a skin biopsy. And again, we don't do skin biopsies as part of clinical care. It would be more of a research use. But generally the samples that are testing positive by either PCR or culture or skin biopsy culture, they're negative by these serology tests by STT and MTT.
Hmm. Wow.
So um,
Yeah, but
there's this huge disconnect.
I just feel like we are so far behind, right? Because I'd like to kind of segue this into the direct detect testing and how it's not really. I mean, I don't think I can go use my insurance, go to my doctor, and say, do a direct to test Lyme test. I don't think that's possible. Are you aware that it is, Dr. Horn? No, right? Okay, so you're shaking your head
Well,
no.
I mean, you can order it, but like the Borrelia is. So we also, how I told you we tested all the samples. We also tested all the samples by PCR for Borrelia. So I think it was three different species of Borrelia, and then different tick-borne infections like Babesia, like Anaplasma. And again, depending on where you are in the US, some of these other tick-borne pathogens have a much higher incidence. So
Yep.
on Long Island, there's a lot of Babesia. In the upper Midwest and Wisconsin, there's a lot of Anaplasma. And again, ticks often don't just have one thing.
Yeah. But do you think that what do you think is I'm going to jump ahead a little bit, but to me, we had somebody on recently talk about genomics, and I love that, right? As a geek, I love AI tech and the possibility of leveraging all of this science technology to use genomics, and that's a totally different approach from a two-tier antibody response to a directed test looking for the actual bacteria itself. To now basically saying, let me get a sample of your blood, let me erase out or wipe out all of the human component and see what's left. That's a whole different world. So I feel like, it's just like we are so in the Stone Ages here. So have you heard about genomics being used in the Lyme space above and beyond direct detection? And do you think that's a promising modality to test for people in the near future?
So, one of the cool things about the biobank is we require all sample users to give us data back. So, did things test positive or not on their test? So, there is a commercially available test right now that looks at cell-free DNA. So, it basically takes a plasma sample, it wipes out all the human stuff, and it looks for foreign things, right? So, foreign DNA like bacterial DNA. It picked up like of the ones that were two-tier positive, it picked that we sent them, it picked up a third of them with this test. And
Wow.
the ones that had EMs that were STT negative, it picked up half of the ones we sent them. So it was about 50%, which was a lot better than what we, what we currently have. There are a lot of tests in development right now, and there's a program called LymeX, and it's the LymeX Diagnostics Prize. Are you familiar with it?
Yes.
We are.
I hear you
Um,
are actively on that committee slash board slash whatever, helping evaluate the winner,
Advisor.
correct?
I'm an advisor.
Advisor.
Yes.
One
But
of the many
anyway,
hats you wear, Dr. Horn.
yes. But anyway, it's a private partnership between the U.S. Department of Health and Human Services and the Stephen and Alexandra Cohen Foundation. And we're now in phase 4. And, they're really trying to detect active infection. There's some good teams that are working on this that are getting close, and they're at this stage they're getting ready to do their clinical studies to get the data to go to the FDA. So I do think we are going to get some better direct detection tests, but again, even though you get FDA cleared, you actually have to get it into the clinic. You have to get adoption from providers.
Yeah.
So there's a lot that has to happen. Once we get more tests, it's not the end, but I think there's a lot to be hopeful for, and a lot of it is having well-characterized samples. And so many of those teams, and even the teams that have not advanced in LymeX, have used biobank samples. And we have 100 more than we have 125 plus projects at this point, and a lot of things didn't work, but that's okay
Yeah.
because
You learn.
you learn, and someone has a good idea, and if it didn't work, well, they've moved on to something else. But there were a lot of things that have worked, and there are a lot of things that I'm excited about. And there's some good data in urine right now.
Why is urine such a weird topic in the Lyme space? Because DNA Connections is somebody we had on. They're not allowed in New York. And we get such hate over urine-based Lyme testing. Why? Do you understand that? I've never been able to understand why it's such a
I
controversial
don't.
thing.
I don't. Well, so for me, if you're going to poke me with a needle, or you're just going to say, "Hey, can I have some urine?" I think if we can have a good test in urine, that would be a lot easier. And it would be a
Yeah.
lot easier for kids, because a lot of kids get Lyme disease, like younger kids. I mean, they're crawling around in the grass, they're lower to the ground. Um, yeah. So I don't, Lyme is so weird that there are things that are controversial, and I I just don't understand it. I mean, we need data. We need to understand if these tests work, and let's just try things out. And if we can get a great urine test, that's awesome.
Yeah.
Uh,
Can
yeah.
you give us some specifics about the Limex competition? Because another thing we learned, we love to like kind of build upon every guest. So another thing we learned is, in addition to genomics, you hit on something I think that was important that shocked me, because I thought if you said, "Hey, we're taking out the human part of the blood and we're seeing what's left," I go, "Well, that helps solve the Lyme plus problem, right? The whole chronic Lyme problem, where it's more than
Yeah.
just Lyme. Otherwise, you have to do these antibody tests for every tick-borne infection
Right.
and not tick-borne infection, right? Or you have to do a direct detect test for every tick-borne infection, which is going to be a lot of money and very costly.
Right.
And it's not really practical. So to me, I thought, well, with genomics, we can just say what's left, and that's a definitive answer. But then you just touched on it. You said, well, it was still better than two-tier testing, but it wasn't perfect. And I think that's because a lot of these pathogens exist in low concentrations in our body. You can have a very few amount of spirochetes in the human body, whether it be tissue or blood, causing severe symptoms. And that's why even when you with genomics, you don't have these problems. So we had somebody on very recently who said they're leveraging AI, and they're building this proprietary AI algorithm to say, "Hey, if I take a sample of blood and there is no actual pathogen in it, I can look for traces of the pathogens using genomics if it was in that sample at some point, even if it's moved on and floated on somewhere else into a tissue." So that fascinated me, right? So I don't know if you've heard about that kind
Yeah.
of technology or anything similar in the Lymex space you can share with us to give us a cool, fun story about testing and some cutting edge stuff.
So this is not someone in the Limex space, but one of the huge problems is lack of well-characterized samples. And so we have these for Lyme. We don't have enough, but when we get into these other tick-borne diseases, there just aren't enough well-characterized samples. So this is one of our collaborators. This paper is under review, and they're working on an early Lyme classifier to distinguish Lyme from other tick-borne infections. Because again, it's not like you were saying, it's not just Lyme, and you don't want to have to test for everything individually because it's time consuming, it's expensive. But they were able to basically use machine learning to recapitulate, to expand the number of samples, and basically using AI to make in silico like fake samples that behaved like the other Anaplasma and Babesia samples, so then they could increase their sample numbers by having a very small number of real samples and then making basically virtual samples. It was
So
really
basically,
cool.
so basically, I'm taking 1% of your blood out of your body, but I can scale that using technology to simulate 50% of your blood to see if Lyme would exist in 50% of your blood based on a simulation. Essentially, it's kind of what I'm hearing in my brain, right? Like it's almost like
Well,
you're scaling it
I
up.
think that's the next step. This was more like, hey, we only had had 10 Babesia samples, but we really needed a cohort of 50. So
Ah,
let's expand it. But I think you could still apply that individually.
yeah.
So there's a lot of cool stuff going on.
That is freaking cool. Thank you for that story. That was it's now you've built to my knowledge base for the next guest. So this is awesome. I have to ask you, and I don't mean to be too pushy, but we had and Allie knows how much we love MIT and how much we love Dr. Mickey Tal. I mean, we've met her in person. She's fantastic. And she has her own biobank. Okay, you love her too. Good.
Yes.
So if somebody's not watching on YouTube, you just give us the
Oh,
heart
sorry.
symbol.
Yes. Hi,
So
Mickey.
yes. So now, and we pushed her. I said, hey, and Richard, I had her. We had on the long form podcast. I said, Dr. Tal, and we didn't know really. Well, Rich knew you, but I didn't know you at this time. I said, the Bay Area Lyme has a biobank, and they're doing exactly what you're doing. Why are you not collaborating with them? And she goes, well, we're trying to. So, has there been any progress about collaboration between you and Dr. Tal, sharing samples, sharing data? Because all of this is around data collaboration too, not just intellectual, have a discussion and learn, share data, increase your sample sets. Like, what's that look like from a collaboration standpoint?
Yeah, so Dr. Tall is amazing, and I actually just saw her a couple days ago, which was really great. So, you know how we've been giving out samples? She has a lot of our samples along with her collaborators, and we're doing this big project with with Mickey, with her collaborator NASA Senate Armstrong, and some additional collaborators at Yale. So, yeah, it's really great, and we've given out 25,500 aliquots of sample of so aliquots are just like
Let's say,
little
what kind of unit measurement is that, aliquot?
it's like so did you ever cook and you're making something but it's too much and you have to freeze it
Yeah.
Yeah.
like you made like
Yes.
stock and then you just put them in little baggies and yeah it that's the aliquot like
Got it.
from the big pot to like this or spaghetti sauce it works for sauce too but anyway we sent the 25,000th aliquot to her
Wow.
at MIT in January, which was really cool. So yes, we're definitely collaborating, and I her Maestro study is so unique, and so Maestro stands for basically measure absolutely everything, and which is great, and we're going to learn more about different sample types and what works for which diagnostics. And yeah, I mean, the Lyme community is really collaborative, and it's so important because it's really complicated and everybody has a different piece to the puzzle. So yeah, and we've been yeah, we've been working together since before 2020. So yeah.
That's so good to hear. There's so much knowledge that you dropped on this podcast. So I have to ask, there's so much. I mentioned just yesterday being told all this misinformation and having to direct them to various resources. Are there any online resources that you're aware of that are reputable that we can direct people to, a web link, something just to cite all this data? Is there something on Bay Area Lyme? Do you have a website? Because I would love to be like, hey, here's a scientist who's freaking brilliant. Go check out Dr. Horn, and here's her study. I mean, granted, I found you on various,
Yeah.
websites like researchgate.net. That's pretty dense. Like, is there anywhere where this is summarized for the patient and for the doctor to see it in a quick little, recap? All these key points we discussed. So if a doctor sees it, they might reconsider their flawed approach to all these patients that we come into contact with on a daily basis.
Yeah, so Bay Area Lyme has we do a lot of blogs about these complex scientific topics and some of the different diagnostics and development. So it's all on Bay Area Lyme's website. Um, there's also a really important website called VectorWise, and they do CME for clinicians, and that's run by Dr. Elizabeth Maloney, who's a retired family practice
Oh,
physician. and she has a lot of amazing CMEs about Lyme testing, and there's other people that have contributed to the CMEs. And I think for clinicians, that's a good place to go, and all the CMEs are free. And I think we really need more clinician awareness and education. And I think that's a huge gap. And I
Yeah.
hope that, unfortunately, there's so many people suffering from Lyme disease, but with so many people, I'm hoping that many of the physicians that are training now might know someone or might be curious or might be open to, really tackling these infection-associated chronic illnesses because there's a lot of people suffering, and we really need providers that know how to treat these conditions.
Yeah, I'm going to put the link in the show notes as well, but it's vectorwisecme.org. And when you say
Yes.
CME, that's really something that a medical professional can take, get credit for. It's a formal training they can get essentially to kind of keep up with their education, right? That's at a general what this is, right?
It is, but I
Okay.
think the Lyme community is really savvy, and there's some really it's also Lyme Plus on there, and so there's a lot of talks by Dr. Monica Embers. There's things on Bartonella, but there's a really good one from Dr. Embers about the gaps with current Lyme diagnostics, and then Dr. Maloney has done ones on diagnostic principles and serology. So a lot of the things that we've shown in this paper, um, people have known for a long time. It's not that it's new, but I think that we were able to really show it in a way that stands out and makes you say, "Oh wow, these tests really don't work well."
No, they suck, right? I mean, they really do. To Rich's original point, and we're gonna drop the link in the show notes too for this. So obviously we talked about the vectorwisecme.org, but what we did in prep for this interview is we looked at the Bay Area Lyme Foundation blog post, as you noted, and we're going to put the link in there. But it's new Bay Area Lyme Foundation study shows common FDA-cleared Lyme tests miss 64 to 78% of early cases, underscores urgent need for improved diagnostics. This link would be great to share with the doctor, right? Because it's so easy to
Yes.
read. You read it within a few minutes, you're like, whoa, like you're blown away by it. And you mentioned Dr. Embers, who we love. And I have to give you a heads up, Dr. Horn, because when I met Dr. Embers for the first time last fall, I don't get nervous about meeting celebrities. I get nervous about meeting really smart people. So I was like shaking walking to Dr. Embers. I'm like, Rich, I couldn't, I was so like wigged out by it because she was so smart. I was so intimidated by her. And now when I see you, hopefully at iLads in the fall, I'm going to have the same reaction to you. If I start shaking, you know why, because you're so smart. I'm going to be intimidated by you.
Yeah, and I would say too, well, one, don't be intimidated. Um, and I'm just cocktail party smart about a lot of this stuff.
That is not true.
Not true.
But no, but actually a lot of the scientists and the technologies, and the new technologies that are coming, and some of the things that you can do now that you couldn't do like even 3 years ago, it's really amazing. And I
Yeah.
think we're at a good spot in Lyme research. I mean, we still have a long ways to go, of course, but I think there's a lot to be hopeful for.
Yeah.
So
And I think too, in terms of resources, if people want to know more about the biobank, there's a whole biobank section on the Bay Area Lyme's website.
Well, Dr. Owen, you've been really kind to spend the 90 minutes with us that we asked of you. And before Matt says any more weird things to you about how he's going to be afraid of you when he meets you or any of those kinds of things, we should probably wind down. And one of the things we like to do here as we wind down and take boot camp is to make sure that folks understand that there is hope. And when we first started doing this podcast almost 6 years ago, almost every episode ended, on a downer because the place we found ourselves was that there was very little hope. And although Matt and I have now characterized the current testing as sucking, and you gave us the statistical proof that the test sucks. The other thing you've done for us, which I think is really appreciated by us and by the folks who are listening to this podcast, is that there's hope on the horizon in the very near future. We're going to have great tests. And we're going to have great testing. And one of the other things we should be encouraging folks who are listening to this podcast to do is make sure that they ask their providers to make sure they are going through the process of taking continuing medical
Yeah.
education. Find some of the really good resources that are available, and if they really want to be aggressive, urge their practitioners to go to ILADS and take the ILADS training and get the ILADS
Mhm.
certification. Because at this point, the best way of getting diagnosed, if truth be told, is by having a competent clinician ultimately make a clinical diagnosis. Because right now, that is the best way of getting a diagnosis, and is the best way of getting yourself treated. So there are current tools available for folks, and that is education for your practitioner.
Mhm.
And there are unbelievably good tools on the horizon. And again, Dr. Warren, thank you for spending so much time with us and sharing your brilliance with us and our followers.
Yeah, thank you so much for having me. And I would say too, for patients, another way to get involved is to sign up for My Lyme Data if they haven't. I mean, My Lyme Data has just surpassed more than 20,000 participants in their registry, and that's how we get information about what's actually happening to Lyme patients. And it's such an important resource. And I would just encourage people to sign up for My Lyme Data and to just have hope. I mean, one of the things that's been amazing for me is just how many good things that are coming out. We just had the 31st biobank publication accepted today, this morning. And
Congratulations.
thank
Okay.
you. Okay, this paper, this was 28. And this paper came out on I think, April 21st. So like there's so much good stuff happening, and we still have a lot of work to do, but we should be very hopeful and excited. And I think just to the regular community, information about ticks and Lyme disease is filtering down, and it's really important that we all just try to educate our peers. And like Ali always says, correct misinformation when you see it. And that's something that we can all do. And I mean, I'm curious where we'll be next year because I feel like we're making so much progress.